Good morning, everybody. It is really nice to welcome you to the annual conference of Health and Care Research Wales. I'm Kieran Walshe and I'm the Director of Health and Care Research Wales, and it's my pleasure to be chairing this opening plenary. We have three great speakers in this opening plenary who I'll introduce in a few moments, but just before I do that, I've got a few housekeeping points about the way the conference is going to work. Over 600 people have registered for this conference. It's the second year that we have run it virtually, and I have to say one real advantage of running it virtually has been it's made it much easier for people to join the conference and take part in the sessions from across Wales, but also welcoming people from across the UK and beyond, representing not just the research community, but also patients, members of the public, research funders, people working in the NHS and in local authorities, and in social care and in Welsh Government, and all sorts of others besides. So everybody is very welcome. We do encourage you to tweet if you use Twitter, using the hashtag ResearchWales21, and our target here is to get that trending, so with your help I'm sure we can do. Also during this plenary and in the other sessions that we're running today, you've got the opportunity to ask questions and contribute to the chat. You can see the chat on the right hand side of your screen, so you can make comments into the chat to others, but also if you click on the ask button next to have a question, it will open up the question window, and there you can both ask a question yourself and you can also upvote questions that other people have asked. We really encourage you to do that. What we found last year was that this actually makes it in many ways more participative than it would be a face-to-face conference, where who asks a question is relatively random and it all happens at the end of the presentations. Here you can ask a question at any point, and actually really encourage you, as our speakers are speaking, to ask questions during the sessions, because then other people can see your questions, they can upvote them, and then as chair, when we come to the Q&A at the end, I can see the questions that people have regarded as most popular, and I can filter those into our speakers. So do encourage you to use that both in this session, but also later on during the day. The topic for this first plenary is about learning from the pandemic, about health and care research, and we have three speakers. Our first speaker is Eluned, who's the Minister for Health and Social Services. Now, she's not actually able to join us live today because she's at the state opening of the Senedd this morning, and I kind of understand why that does take priority. That was scheduled after our conference. So we've got a recorded presentation from Eluned, and we'll turn to that in a moment. Our second speaker is Iain Bell, who's fairly recently come into his role as National Director for Public Health Knowledge and Research at Public Health Wales. Before that was Deputy National Statistician for Population and Public Policy at the Office for National Statistics, where he was very involved in leading ONS's response to COVID-19 on the public health data set and health and social stats, and was also the lead person for delivering the 2021 census in England and Wales. So delighted to have Iain joining us, and delighted Iain has joined Public Health Wales. He's going to speak straight after Eluned. And then our third contributor today is Rob Orford, who's the Chief Scientific Advisor for Health to Welsh Government. Rob's also the head of the Health Sciences and Allied Health Professions for Welsh Government, and he's led with Flisbene the Technical Advisory Group, which has been absolutely central in the pandemic to trying to bring research to bear on policy and practice in Welsh Government and the Welsh NHS and care system. So Rob is going to then follow immediately on from Iain. We're going to keep everybody quite strictly to time, so that we have time at the end for about 15 minutes, perhaps 20 minutes or so of Q&A, questions, discussion and so on arising out of our three presentations. So a reminder again, please do use the Q&A function to raise questions and to look at the questions and points that other people have fed in. So without further ado, we'll move to our first presentation from the Minister for Health and Social Services, Eluned Morgan.
Bore da, a ga I ddechrau trwy ddiolch yn fawr I Ymchwil Iechyd a Gofal Cymru am y gwahoddiad I siarad gyda chi yn eich chweched cynhadledd blynyddol. Dwi'n falch iawn bod cymaint ohonoch chi yn bresennol er weithio'r ffaith I fod yn rhithwyr. gyda chymaint o grwpiau a sectorau yn cael eu cynrychioli, cynnwys gwasanaeth iechyd, academia, gwasanaethau gofal cymdeithasol, llywodraeth, gofal cymdeithasol Cymru, y sector gwyddfoddol, cyrff cyllido ymchwil ac wrth gwrs ein partneriaid ymchwil cyhoeddus. Morning, can I begin by thanking Health and Care Research Wales for the invitation to speak to you all today at your 6th annual conference. I'm really delighted to see so many of you here, albeit virtually, and that so many groups and sectors are represented here. We have representatives here from the NHS, from academia, social care services, government, Social Care Wales, the voluntary sector, research funding organisations, and of course, public research partners. Now, as Minister for Health and Social Services, my portfolio covers much of what Health and Care Research Wales does. The aim, of course, is to improve health and well-being by using research to focus on prevention while improving care, treatment, and service delivery for those who do need it, not just during early or older years, but throughout people's lives. It's never been more important to ensure that the role of health and care research in underpinning and driving transformation is recognised and is valued. Over the last 18 months, the research landscape has been transformed to meet the urgent needs created by the COVID pandemic, and the response of the research community in Wales has been nothing short of incredible. Wales has played an active role in the UK-wide COVID research effort at a pace and scale that has never been seen before. Together, we've helped identify treatments to improve the outcomes of the sickest patients and participated in the discovery of the effective vaccines that are saving lives today. Our contribution to the national vaccine trials has been outstanding, and we've contributed to platform studies such as Recovery and REMAP-CAP, which have found treatments that lower the risk of hospitalisation and death. Through the NHS, academia and industry coming together, we've been able to put Wales on the map, showing that we can set up and deliver studies quickly. Nearly 50,000 people in Wales have been recruited into 110 COVID research studies, which is an incredible achievement. This couldn't have been done without the commitment and skill of our research community and the people who stepped forward to contribute to the studies and make the research possible. I'm also proud to fund the new Wales COVID Evidence Centre, another collaborative effort which draws together the latest UK and international research findings to provide us with the best possible available evidence to inform policy and practice. Although still in its first year, the centre is already making a significant contribution, undertaking evidence synthesis that are directly feeding into policy and service decisions. For example, it's already completed reviews on face coverings and the benefits these have on the prevention of COVID transmission, the impact of a pandemic on the mental health of health and social care workers, the effectiveness of infection control measures in education and childcare settings, and the transmission of COVID in closed and semi-closed spaces and outdoors. I'm pleased to see the focus of today's conference is learning and looking forward. The last 18 months have seen a big change in how we deliver research within health and social care. Many lessons have been learned and new approaches to delivery of care effectively have been developed. It was good to see the priority that was given by Health and Care Research Wales in its funding schemes to studies looking at the impact of COVID on non-COVID conditions and the lessons learnt from COVID that can help us to improve service delivery. This covered areas such as the screening of diabetic eye disease, the impact of health inequality and mortality of people with epilepsy, and the health economic impact of COVID on care and support for people over 65, just to name just a few. Now, as we begin to recover from the most challenging period the NHS and social care has ever faced, we need to continue focusing on research success and lessons learned. This year, with my counterparts across the UK, I published a bold vision called Saving and Improving Lives, the Future of UK Clinical Research Delivery. With a focus on tackling health inequalities, bolstering economic recovery, and improving the lives of people across the UK, it sets out an ambition to create a patient-centred, pro-innovation and digitally enabled clinical research environment which empowers everyone across the NHS to participate in delivering research and ensures that patients from across the UK are supported to take part in research that is of relevance to them. The pandemic demonstrated that it's possible to create an ecosystem where research is more efficient, more resilient, and more effective, where partnerships across all sectors are strengthened, and where we think differently about how and where research is delivered to meet the needs of future generations. We mustn't slip back into old ways of working and complacency, but we must seize the opportunity on offer, playing our role in harnessing Wales and the UK's potential to be international leaders in health and care research. Now, I know that Health and Care Research Wales continues to strive to put the public at the heart of all it does. Strong public involvement improves the quality and relevance of research and helps ensure that research delivers public benefit and addresses public need. The Discover Your Role programme is one example of an inclusive approach to ensuring that the public continues to shape and influence the research. Another is the recent research prioritisation exercise. How can we best provide sustainable care and support to help older people live happier and more fulfilling lives? And that was run in partnership with Social Care Wales and the James Lind Alliance. The exercise featured heavily the views of carers and those in receipt of care as we sought to identify priority unmet need that research can help to address. The identification of priority research questions and the use of research evidence in health and social care will be as crucial as ever as the Welsh Government delivers its 5-year programme for government. It's great to see the close alignment in current funding calls, for example, between Health and Care Research Wales activities and the commitments outlined in both our programme for government and A Healthier Wales, which is Wales's government strategy for health and social care services. Now, much of what I've said today speaks to how important a strong and vibrant research community is in developing and delivering high quality health and care research that helps deliver my priorities as Minister for Health and Social Services. The latest annual report from Health and Care Research Wales, published today, is testament to the work undertaken and recognises the impact that research has on the health and well-being of people in Wales. But there's still more to do, and we must continue to find ways to punch above our weight in our efforts to invest in our health and care research base and get Wales's full share of UK level resources for health and care research. To do that, our research must be of the highest scientific standard, internationally competitive and world-class. Diolch yn fawr am helpu sicrhau bod Cymru yn cael ei gweld fel gwlad ble mae ymchwil yn cael ei gwerthfawrogi ac yn cael ei chydnabod yn gongolfaen i iechyd a gofal cymdeithasol. Dwi'n edrych ymlaen at barhau i gydweithio gyda chi mwyn adeiladu ar gyflawniadau ac i ddod a buddion ymchwil i bawb. Gobeithio cewch chi ddiwrnod cynhyrchiol a diddorol. Diolch yn fawr iawn. Thank you for helping to ensure Wales is seen as a place where research is valued and recognised as a cornerstone of health and social care. I look forward to continuing working with you to build on achievements to date and bring the benefits of research to everyone. I hope you have a productive and a fulfilling day. Diolch yn fawr iawn. Thank you very much.
Bore da, good morning. It's Iain Bell here, and I'm delighted to join you after that brilliant speech from the Minister. As Kieran mentioned earlier, I am currently Director for Data Knowledge and Research in Public Health Wales. But prior to that, and for much of the pandemic, I was the Deputy National Statistician at ONS for Population and Public Policy, which of course did also contribute from Wales to the research landscape with our office in Newport there. And so my job there covered a range of different areas: the public policy analysis, wide-ranging different set of social interactions around the impact on communities, housing, homelessness, equalities analysis, to name but a few. The health and life events area, which of course became incredibly important during the pandemic, and the delivery of the 2021 census in England and Wales. And so what I'm going to do is do a bit of reflection on a few themes built on the experiences in ONS, and then reflect them through into how we take forward the health and care research landscape in Wales. So my first reflections, first of all, responsiveness matters. This was a period when we needed to step up as a community and deliver the answers to the questions people needed across a wide range of different areas. The second area is around communities and how they matter, and the different communities that formed online, virtually, as well as locally, and how the pandemic laid bare inequalities and the way different communities fared. And then finally, good research can be quick research. I think too often we've prided ourselves on how long it takes as being part of the measure of quality, and I think the pandemic threw that into sharp relief. And so I'll go through each of these in turn with some examples and then take it through from there. So in the early days of the pandemic, we didn't have much in the way of the health data coming through in ONS. But we did know that as we went into lockdown, this was going to see unprecedented societal change and economic change. And so quickly, ONS stood up. It was round about the 16th of March. The idea was first there to utilise our online tools to do a weekly opinion survey. Went live into the field on the Friday, the 20th of March. And results coming in all weekend. First results back from government on the 24th to government on the 24th of March, and then published weekly thereafter. Now we have equivalents in Wales run by Public Health Wales and Ipsos Murray for Welsh Government in Rob's area. And those have provided a bedrock of information about actually how willing were the public to respond to the interventions which were coming in, and the compliance, which I don't think many of us thought would happen at the start, with measures such as social distancing, stay at home, and work from home. And those surveys provided a barometer across those, but also vital information on some of the wider impacts. So such as the top chart there showing loneliness during the pandemic, which peaked during February, during this the lockdown this year across Great Britain. But equally, we're seeing unprecedented shocks to the economy. And the chart below just shows some of that around actually bank spending through credit card and debit card, and the ability to monitor the impact of the lockdowns on various sectors of the economy and the bounce back there. But one of the core bits in ONS we set up was the COVID-19 infection survey. And I'll still never forget, it was mid-April 2020, and we had it designed in partnership with IQVIA and University of Oxford and Public Health England and some SAGE members, a pilot of 500 swab tests for COVID-19 and 500 blood tests. And on the Friday night, we went back thinking this is all great, this is fine. And then on Saturday evening, sat there watching Britain's Got Talent in my classy way, and I get a phone call saying, actually, we just had a request. Could you get to 10,000 people for swab tests by Wednesday, please? And so that was how it started. So we stood up the challenge. We got there. It went to 10,000, not quite by the Wednesday, but we got it there. and then expanded that from across England into Wales, Northern Ireland and Scotland, and expanded it up by October so that it was carrying out 150,000 swab tests a fortnight, and it's kept at that level. And an essential and unique barometer of the impact of COVID-19, as uniquely it provided the asymptomatic as well. But alongside that, in December, we recognised the change with vaccination and the need to move much more into antibody testing, and scaled up from February this year to get to around 120,000 a month people providing antibody tests through blood testing. And it's just shown the phenomenal impact and success of the vaccination programme across Wales and wider across the whole United Kingdom on that antibody level and monitoring it. So it really was a period where you had to keep the flex going, change, respond to the questions of the day, because if you didn't, the pandemic had moved on and the science and research was somewhere else. And that ability to be responsive was crucial to keeping going through the pandemic and monitoring it as it changed and moved from Alpha to Delta variant. We also learned communities matter. And these different impacts on different communities. In the first wave, it was very clear that the Black African community had one of the highest excess mortality rates. Kieran mentioned the public health data asset, but this ability we had to link the ONS census data through with GP records, mortality data and hospital episode statistics and vaccination data has provided a unique ability to assess this and look at it in different lenses, control for socioeconomic factors. And really interestingly, although in the first wave, the Black African community was most affected in terms of excess mortality, for the second wave, it was Bangladeshi and Pakistani communities who were most affected. And I don't think we understand yet why that happened. And if we move on to the next slide, we will see that actually we have, if we move and click on the visualization, then we will see here that it had impacts locally as well. This animation is showing it July at the moment, but even when mortality was relatively low, there were still differential impacts in different parts of the country. And as you can see there, back in April, you could see just how severe the impacts were in some of the areas of the Northwest and beyond. And that ability to show these communities those stark inequalities is something we've got to take forward and build on. And if we move on to the next slide, then what we can basically what we can then see is that we need to keep going in that understanding, because we still don't know fully what the reasons were for why different communities were impacted as differently. My final point around the pandemic itself, good research can be quick research. I've picked here one example on immunity waning. This was work done by Oxford University, utilising the data from the COVID infection survey and looking at the vaccination data alongside it. And really in September, they were able to provide the following selection of results around it, basically showing 2 doses remain the most effective way to ensure protection. But crucially, the first of all, effectiveness is reduced compared with Alpha. And secondly, it began to show the immunity waning and suggesting that after 4 to 5 months, the effectiveness of the 2 vaccines were similar, even although Pfizer provided higher initial protection. That's vital. That's 4 to 5 months after that group would have had their second jab, and we're already knowing this about immunity waning. The Minister mentioned the work on vaccine trials here in Wales, and that effort to step up and really deploy those at pace has really truly helped the understanding. I know how long it used to take. We'd design an RCT, it would take months, we would then bid for funding, we would then go through the proper protocols, and maybe a year later we'd set it going. That and the pandemic has shown we can do things quicker and protect the public quicker. And I think it's got to be one of the core lessons for us that speed is not at the hindrance of quality, but we have to keep our eye on quality as well. And I think my final point I want to make is that we cannot and should not go back, as the effects of the pandemic are still with us. First of all, we see what happened in ensuring the NHS could cope with COVID-19. And the bar shows the first confirmed COVID case, and the top line shows the waiting over 36 weeks for treatment. And it's gone for 5 to 6% of people waiting over 36 weeks, up to over a third. So we have a situation where, as we go into the winter with the usual pressures, we have an NHS with a large amount of backlog in the system, to use the term used, but people who will be needing treatment and potentially presenting in emergency. And we know we've got persistent health inequalities. The COVID-19 mortality rates showed it, with it being twice as high for women living in the most deprived areas compared to the least deprived areas. And as part of our protecting ourselves from COVID-19 during the pandemic, we didn't exactly do too well on health-harming behaviours amongst ourselves, and only 1 in 3 of the Welsh population were actually around a third of the people in Wales follow less than 3 of the 5 healthy behaviours. And only 37% of adults reported having a healthy weight. And you can see how much the lockdowns did to increase that. Alcohol consumption went up for about 1 in 5 of the population. Alongside it, physical health, the most deprived areas were worsened significantly, with around 43% in the most deprived areas saying they're in worse physical health now post-pandemic than they were at the start of it, and more people feeling unhealthy. And so my basic viewpoint from this is that we have an ongoing public health scenario with increased amount of people waiting for care, higher health harming behaviours, and an ongoing public health situation that we need to work out how to manage and how to deal with the inequalities that are within the system. And so that ongoing need is there to keep research going quickly, keep results coming quickly, and make sure we continue to tackle and improve the health of the population of Wales, not just during the pandemic, but beyond it and into the future. And so my reflection is that this is the best place we can be in terms of moving forward, but let's keep going. And with that note, I will end, and I will hand over to Rob Orford, introduced already, and delighted to hand over to Rob. Thank you very much for your time.
Thank you very much, Iain. That was absolutely fascinating and illuminating. So thank you so much. I'm going to talk to you reflections, some of which will touch upon Iain's points. And I think if n equals 2, we're pretty close to a trend line. So if somebody else repeats it today, it has to be true. So science is a world that has possibly been pushed into the public's imagination quite a lot in the last 20 or so months. Has it been overused? No, I don't think so. Has it been misused? Yes. Accidentally and deliberately. So what is science, and why should we use science? So that question or that problem or that hypothesis that you have, that you then systematically collect information and data and curate it together and interrogate it such that you create new knowledge, that is science, and it comes with degrees of confidence. And I think it's important to understand the strengths of science and the weaknesses as well. It's often uncertain. There's often things that we don't know, and it's okay to say that. The ultimate arbiter of science really is evidence, and things change over time. And the difference between science and politics is that that there's not just one unassailable truth. Science changes, facts change, evidence changes, and so we have to change our advice as we go. So what we found really useful throughout this period is using the probabilistic yardstick, a really good instrument that we have embedded in our papers and our thinking, such that we're able to convey uncertainty and probability. And it's really important practice that people consider using that you consider using that in your writing and your communication, such that you can communicate how confident you are of something happening in the future, whether in 10 futures it will happen one time, or in 10 futures the outcome may happen 9 times. So that's really important. So I'm trying to do 2 things at once, which is always quite difficult for me. 20 months ago, I think my first stage meeting was the 11th of February. We started talking about this 100 nanometer particle of coronavirus. We knew very little about it. We didn't know how it spread. We didn't know the doubling time. We didn't know how to decontaminate. We didn't know the case fatality ratio. There were lots of things that we didn't know, lots of knowledge that we needed that we didn't have, and there was lots of uncertainty. And throughout that period, there's been a huge expansion of our knowledge in this one small viral particle, this novel virus that came along. In thinking about this, we worked together, we worked collectively as experts. We created the Technical Advisory Group within Welsh Government, which is a similar group to the Scientific Advisory Group for Emergencies in UK Government, to try and understand all the things that we didn't know and try and address all the problems that we knew that we would have because of the emergence of this novel coronavirus. So one of the things that we did quite early was talk about the different harms that could be introduced by the epidemic in Wales. And we came up with a framework of 5 harms. Originally, it was 4. First were the harms arising from COVID infections themselves. We know there's been around about 400,000 detected infections through PCR and other tests in Wales, so it's likely to be much higher than that. There's well over 8,000 people that have unfortunately and very sadly lost their lives during the last 20 months. And there's been an inordinate amount of pressure, as we know, we hear in the news about the impacts on the health service, with thousands of people having delayed or missed opportunity to have surgical treatments and diagnosis of treatable conditions, and that will take a long time to get over. There have been impacts that we've accrued educational harm from switching education off. Every week a child misses education. The estimate is £1,600 of lost learning over time. So there were lots of harms associated with the population control measures that were put in place to protect the NHS and people's health. There was a significant amount of economic harm, as we know, with as much harm as the First and Second World War being accrued into our society and system. And then there's harms that Iain described that are exacerbated by COVID, these harms from inequalities, whether you're rich, whether you're poor, whether you're old, whether you're young, where you're born, the genes that you inherited, and invariably we've exacerbated these. COVID's exacerbated them, and the approaches that we've taken have exacerbated them. So in thinking about SARS-CoV-2 and COVID and controlling it, we know that any intervention introduces harm. There were no harm-free options. So by reducing infections, you create educational harm, you create economic harm. So it's very difficult, and it's been very difficult for ministers and policymakers to think about these harms and try to quantitate them to make the right decisions. So what have we done? Well, we've tried to take that scientific method, we've tried to take the evidence and put it into action. Ultimately, that creation of new knowledge, the power of it is the application of new knowledge to address those problems. So whether it's us looking at what the road ahead might look like under different circumstances, whether it's the protective control measures, things like masks, how children can safely have an education in school. And all of these have been difficult. And all of these have come with their own challenges, and our ability to be able to talk together across disciplines and come to consensus statements where we can. And we haven't always been able to come to consensus statements. Lots of talk about groupthink and sheeple and hive mind, all these wonderful terms to describe SAGE and the subgroups. Here you can see the technical advisory group. I think this is probably Fliss chairing this meeting. But of course, it's not like that. Science is not like that. We're used to challenge. That's the whole purpose, to peer review, to create an environment where you can challenge, where you can say, I don't think that's right for these reasons. There's evidence that's pointing this way. And that's the beauty of it. It's that iterative working together, that collaborative working together to try and come to a consensus together where you can express your uncertainties or your certainties in what you're seeing. So I challenge the idea of groupthink. There's been a huge cast list. The number of people that we've worked with has been incredible. Science is so broad, it's absolutely wonderful. You work with people who are absolutely at the top of their license, that have done this. They've wanted to do it when they were young and they've carried on doing it. And the way they can see and understand things and see further is because of that accrued lifetime amount of knowledge that they have. It's important to recognise that our education systems and our training hone you in to become the expert. And you can see further because you're at that peak of your understanding. It's more difficult for you to come down for your peak of understanding and go to another peak of understanding to become a true polymath. But it's important that in this range, this is the Rumney Valley, by the way, where I live, that you need generalists that need to be able to see across those mountain ranges. So whilst true polymaths are difficult to come by, you know, they are very valuable as well as generalists. And it's something that we really need to consider. The people who are able to contextualize what they're being told by experts and communicate that effectively to non-experts, to be able to ask the questions and understand what might be behind the question and challenge the answer where they need to be. So I think that's something that we need to give due consideration to. How do we culture polymaths and generalists more broadly in science? So the civil service is very good at generalists in the FAST stream and the other programs that they have. One thing we've learned is that you need to stand up and you need to say, you need to get your work out there as quickly as you can, whether that's through publishing or through Twitter or through radio interviews or articles, to get your work out there and discuss it. One of the consequences of doing this is that we've had this rapid expansion of knowledge around COVID-19. So we went from early 2020 to knowing very, very little to knowing almost too much, where the doubling time, like the virus, was around about 20 days in those first 6 months. So how we capture, accrue, curate and mobilize that new knowledge is one of the reasons behind COVID Evidence Centre, for example, where we can systematically look at the evidence base and ask it questions. And I think this is fantastic. The way in which we've used preprints, you know, in the past, I've talked to colleagues that have sent birthday cards to their papers. I think I have a paper coming out that's about 4 years old. And you can see here it's rather small, but the green is the time for COVID papers and the blue is non-COVID papers. So we're working differently and we must not lose that. Science has to be as dynamic as it has been throughout COVID to address real world problems. So we've had this avalanche to deal with. And as I say, we need to find ways of mobilizing these abstruse ideas, these difficult concepts to enable policymakers, decision makers and the public to act on this new information. One thing that's been central to our response is thinking about behavioural science, how people can make sensible decisions, how people can self-isolate or why they may not be able to self-isolate. The worries at the beginning that people would panic, we didn't see panic. People made sensible choices that they thought they were sensible choices about buying toilet paper. Actually, they were quite sensible choices. So behavioural science really has come to the fore throughout this period, and it's something that we need to pursue in that kind of magisterium between beliefs and values, beliefs and culture, and challenge that, because I think the thing that we found is that if you don't engage and think about the population and understand what they want, well, then you're on a real hiding to nothing. And so it's important that we grow and develop our understanding and our use of behavioural science. There are other challenges out there. Lo and behold, there are other challenges that can be addressed and supported and policy supported by science. And personally, I think science should be as commonplace in decision making as economics. Climate change is a great example of where we should be working faster, more collectively, more collaboratively to address the problems that we know are coming down the track. Maybe not in the same speed as COVID, but they are coming down the track. So in terms of what do we need? Oh, my slide's not going backwards. I had a lovely picture of Lord Kitchener then. We need you. We need your ideas. We need your ability to be able to investigate and challenge abstruse ideas, your ability to be able to speak and write clearly, your ability to be able to say, I don't know, but I'll find out, and your ability just to follow that scientific method in addressing problems that we have and will continue to have until we bring the evidence to them. So I'll pause there. Thank you very much. You're on mute there.
Yeah, somebody had to do that, and it had to be me. Many thanks, Rob and Iain, and of course also Eluned for those three great presentations to start the conference off. I've been keeping an eye on the questions, and there are a bunch of questions coming up. Just a reminder to people, if there's something you'd like to ask, do click on the Ask button, put your question in, and upvote others that you'd like to see picked up. One of the things that you both talked about was pace. You know, the speed at which we do research, the idea that quick research can still be good research, and the pace at which we then get those results out there. Do you think in this pandemic we've actually become more efficient at doing research and found ways of doing it faster through efficiency, or have we just been trying to do the same processes but just trying to do them quicker? And because one of the questions that was raised was about burnout, you know, whether or not we can maintain the kind of, you know, frenetic pace that we saw, for example, in the recovery trial, set up and recruiting patients within 2 weeks, utterly unprecedented. But can we do that for normal research and in normal times? So it's a question about how do we maintain that pace, and do we need to actually re-engineer the research system, not just try and do stuff faster? I don't know which of you might like to comment on that. You both touched on it very much in your presentations.
I'll happily go first and say I think there's a couple of things here, because we had quantity and quality during the pace, and I think we can keep some of the pace going while not having the same quantity of work needing to be done at the same time, which could help. I do recognise the burnout side as well, and I think it's about how do we keep the pace going, but with the right level of resources in order to enable it. But I do also think some things got more efficient, because traditionally some processes usually got in the way of doing things quickly. Notably, information sharing, data sharing agreements are notoriously problematic. Yet because there was a collective will that this was a problem we needed to solve, then actually some of those barriers to it came down. I think the other area where I think we got more efficient was in collaboration. I think too often in normal times we compete among different scientific around academic institutes, whereas I think the benefit here was we united against a common way of working, and that delivered huge benefits. So I think there's a degree of keep the pace, but not necessarily to the same quantity. But I do think there are some elements where we have got more efficient, and I think they're around collaboration and some of the barriers, and we need to keep those bits of getting the system going to enable some of the pace without some of the negative consequences.
Yeah, I mean, I can see a comment in the questions from Kerry Hood saying, you know, we managed to get rid of some of the territoriality that often dominates the academic grant application and grant management process, and we might come back to, you know, whether or not the way we allocate resources and the way we decide what research needs to happen perhaps needs to change. But Rob, do you have views on this point about being productive, doing it faster?
Yeah, I absolutely agree. To have a common goal to, you know, to reduce harm that was really important. I think we have to learn from these experiences and say, why would we want to go back? What was different here that is different to non-COVID? And invariably, technology has helped us take out the inertia as well from the system. I think within TAG, we've put online about 145, 150 papers in that period. And the reason we could do that is that we worked collectively together through teams, sharing documents, authoring at the same time, Office 365, those kind of tools that enable you to produce manuscripts in hours rather than days, weeks, months, that perhaps we've got used to. So I do think we need to have a good long look at how the system has changed and ask if we want to go back. I would say that, you know, it's been like running an ultra marathon, and ideally you do that with quite a bit of preparation, but we've done, you know, 3-4 rounds of ultra marathons now. But sprinting is good as long as you rest and recuperate. So I probably wouldn't be an advocate for continue with ultra marathon running, but let's keep sprinting, but then recovering and going again.
Yeah, it has been, in the words, a marathon, not a sprint. That point about the sort of the way we organised the research effort, the collaborativeness, but also the sort of, to be honest, the central direction. I wonder if you have views about that. For example, the recovery trial as a platform trial imposed a discipline upon the therapeutics research community that was very different from the traditional approach, where we probably have seen, you know, and you saw this in the US, you saw a kind of profusion of loads and loads of trials being set up, most of which were not connected, competing for recruitment, without the kind of coordination that made the recovery trial such a massive success. But the recovery trial required people to bury their differences and to accept a degree of central direction. And we saw that as well when recovery was extended into the phase 2 space, where, you know, originally there were going to be a bunch of separate phase 2 platforms, and we ended up with the recovery trial coordinating phase 2 therapeutics research. So, you know, is it good to have more central direction in research, or does that risk the researchers, if you like, losing some autonomy and opportunity to experiment and all of that?
I'm happy to go first there. That's a really good question again. I happen to think in the UK we're really good at organising ourselves and others. You know, program management is really strong. Clinical trials are really strong. So again, having that common purpose to come together to be able to say, where are we going, why are we going, how are we going to get there, how do we know we've got there? You know, we're quite good at doing that. So that's good. The second part it kind of relates to my point about the generalists and the polymaths, that having groups like SAGE or other scientific groups to come together and say, this is the problem, this is how we think we're going to go about it. Do you agree? Yes, let's go. I think that's important, but not losing smaller ideas, smaller groups, individual working that can spin out great ideas. I think that's important, not to throw the baby out with the bathwater by saying we need to coordinate centrally. So yeah.
Well, what about you, Iain? Because I think the Community Infections Survey is a really amazing enterprise, but an example of something that I don't think would have ever happened through the kind of bottom-up grant funding approach that we traditionally pursue.
Yeah, and I think there was definitely a will there to do surveillance, which we'd never have come before, and that centralising, organising force around the SAGE group, really saying, we need this is a gap in our evidence, and we must fill the evidence gap, was really important. I think also in that one, there was a strong amount of political will again for it as well, which really helped, and that came together. So I think that centralising thing, I think the beauty of the Community Infection Survey is it's a resource for the entire community. And therefore, I think less territorialism and more collaboration about how we get a common set of data we can all work from, and then real freedom of analysis, challenge and thought around how we analyse it, to my mind, could marry the best and give a lot of that freedom, but also the ability to critique and do the collection method. And so I think there's something in my mind about separating out the how we get to having an analysable data source and how we maximise and give real independent challenge and accessibility of the data, which hopefully would not lose some of that freedom you were talking about, Kieran.
Yeah, one of the other popular questions in the Q&A list is really about what happens when the evidence changes and we have to change the advice we give to government, and government has to change its policy. How do we? I think the question puts it something like, how do we explain to the public the difference between making it up as we go along and adjusting advice as we learn? And there have been a few, you know, really important examples of this, haven't there? Perhaps the most obvious one being around mask wearing and the way in which COVID is transmitted. So we began by telling everybody, wash your hands, wash your surfaces, wash your shopping when it gets home. Fomite transmission is really important, and we've ended up shifting to saying it's all about aerosols, and that's why mask wearing really matters. Whereas to begin with, Jenny Harris was saying, don't worry about wearing a mask in her early videos with Boris Johnson. So what's your thinking about that, about how well we've handled telling people that the advice has changed because the science has changed?
So I think this for me, this goes back to scientific literacy throughout society and within the civil service, of understanding what science is. And it's okay to say I don't know, and it's okay to say the evidence has changed. The role of the chief scientific advisors have been there since the Second World War, where it turned out science was quite important there too. Is to provide that challenge function. It's not to sugarcoat advice, it's to say, look, this is what we think, and that may change. So it's no bad thing, but I think sometimes that's willfully misinterpreted by some of the media to say, you know, bumbling scientists this, scientists that. Well, actually, that's a part of science that we don't know all the time, and there is uncertainty, and there are things that we need to know. But eventually they'll come back and tell you if it's changed or if we're more confident. But I do appreciate that clear communication, that clear narrative has been missing sometimes to the public of, you know, these are the reasons why. And I think really it's only ourselves to blame there, that we need to be better at coming forward and explaining ourselves. However, I do appreciate that quite a few people don't want to come forward because they will get trolled and they'll get targeted in different ways. So there does need to be more support for scientists and encouragement to stand up and say what they know and what they don't know.
Yeah. Iain?
I would agree with that. I think there's something about it. The tendency we have when we communicate is to want to communicate with certainty. And that works against good science, where you should be communicating with humility, the strength of your knowledge, and actually that there are lots we don't know. And I think that tendency, and it's brought about by the way we interact with media and what works well there, really works against us. And so I think it's partly on us to be brave in our communication about, actually, this is what we can say from this is what we can't say from it, and there's a vast amount we still don't know. I think the other part we had to develop as we went with ONS, when you're developing a survey of this, we had to develop methods as we went. And of course, that meant you're iterating and improving. And communicating that you're iterating and improving didn't mean that the old method was wrong. It's just that actually you've looked at it, you found new and better ways of doing it. Was equally as challenging in my viewpoint, and we have to learn how to do that. We will continually look to do better, and looking to do better. It's similar to a sports person continually looking to do better. Scientists should continually look to do better and improve the research. But I'd agree with Rob, we don't communicate that well, and we need to be clearer about what we do and don't know around it, and explain it in a way. I think the final part is actually to recognise where the public are at and go to there.
Yeah.
There are huge examples whereby if we start communicating from where the science is at rather than from where the public knowledge is at, then we'll never quite meet in the middle. I think a great resource we underutilise is the Science Media Centre, who are actually really good at helping bridging that gap with the media, and can help some of what Rob talked about that nervousness about coming forward.
Yeah, it's interesting. I mean, I was thinking as you were speaking about the way we've communicated the science around vaccines, and I think a really great example of doing it well was explaining to people when the vaccines first became available why we were having a rollout with an extended period between first and second dose, and the benefits to the population as a whole of doing that. I think that was really well communicated, and people understood it and recognised the argument. In contrast, I think we didn't do a terribly good job of communicating about the use of the vaccine in 11 to 16-year-olds, where the public got an incredibly mixed message because different bits of the scientific community that are very important, like JCVI, the CMOs, and science leaders, seem to be saying very different things, and I think that's really hampered the rollout with teenagers. So loads to learn from this. I think we've got time for one very brief final question. I really wanted to come to one which, again, I think it's the third most popular question in the list, which is really about health inequalities. What have we really learned about health inequalities from this pandemic? Because we do know that it is the most disadvantaged parts of our community that have taken the hardest hit from the pandemic in terms of morbidity and mortality. And what should we take from that, for example, for the future of research around inequalities? Iain, perhaps you first.
So the first observation I would have is that the communities who have been hardest hit trust us least. Yeah. And therefore, as a scientific group, we need to work in partnership, and research group, work in partnership, co-produce, recognise where they're at and describe the problems from where they're at. I think the second thing is a change of mindset here. I describe what we do, and I've seen it before in education as well. We find a group who in some way appear to be disadvantaged, be it on health or education, and we do 325 different analyses of all the different ways in which this group are suffering inequality. Yet the amount of research which is devoted to what works in tackling those inequalities is woefully short. And we need to fundamentally change our approach to the research on the back of the pandemic, away from describing the inequality and into tackling and evaluating what's working in order to do it.
Yeah, that's a really important point about trust. Your earlier point about speaking with humility to those communities, I think, is really important. Rob, we've got about 2 minutes left, so a final contribution for you on anything you want to add on that point about inequalities.
Yeah, I think if you look at where COVID has impacted the most for inequalities, you'll see it maps fairly squarely onto 1918 flu. And when we start seeing more consequences of climate change, we'll see the same. And I think we need to be better at this. We need to go back to the beginning in some ways, you know, from the beginning of the NHS, the Beveridge report and others, and think about this more systematically as a society of how we're going to address these problems that we have.
Yeah. We're out of time. It has been a really interesting discussion and 3 great presentations. Thank you, Iain. Thank you, Rob, and thank you also to Eluned. We're going to stop in a minute, give you 15 minutes, strictly only 15 minutes break to get a tea or coffee, and we then restart at 10:45. You should have the links in your email. We've got 2 parallel sessions coming up, one of which is on new initiatives in research, chaired by my colleague Michael Bowdry, and that showcases some of the new funded initiatives that Health and Care Research Wales has launched, and the second of which is on developments in cancer research, chaired by Tom Crosby, who is the National Cancer Lead, and again with a number of contributions connected to work we've been doing to build a cancer research strategy for Wales. So I recommend both of them. They will both be great, and look forward to seeing you back in those rooms in 15 minutes. But thank you to our speakers, and thank you everyone for joining for a great first plenary. Thanks.